Welcome to the HAIO session number 12. We've been doing these sessions since March 17th of 2020. So this is just marking just over a year of the Healthcare Surge Solutions Task Force and many very informative sessions. And a lot of people have worked on this and contributed. And I just want to start with a thank you to all those contributors in the past, and we look forward to an interesting discussion today. Just as very briefly, HAIO is an organization that's been around since 2013, and since 2015 has been working with various hospitals and architects and engineers to develop several collaborative exercises, most notably the healthcare hospital room of the future, which has been a real great collaboration across organizations to address a lot of issues. With the pandemic, we have created what we've called the Surge Solutions Task Force, which has done this 12 sessions so far. On a lot of different topics for related to COVID, and that has been and we've had a steering committee with Richard Barnett, John Meservey, Jason D'Antona, and John Downs, and various other a lot of other participants. Over 67 organizations have participated in this in these 12 HAIO conferences, and a lot of volunteer hours have gone into this, and interesting thought and leadership to create ideas that have been able to be used on many solutions for facility solutions on the project relating to COVID. Today's session is to look forward to, now that we are emerging from the pandemic, asking healthcare leaders about the forecast moving forward. COVID has certainly upended the entire healthcare landscape, and the danger and the breadth of this pandemic has accelerated change. It is up to healthcare leaders to not only keep up with that rapid transformation, but to anticipate what comes next in the new reality. This challenge is ever evolving and impacting short and long-term decisions for healthcare leaders. Today, we want to take a snapshot of the thought process of the healthcare forecast for the next year or years ahead, and seeing what might be emerging from, as ideas now with the emergence from the pandemic. So we've asked our panelists to look at two different issues. One is their thoughts and trends in the marketplace over the next year or beyond. And secondly, what are some ideas for a parking lot of issues and areas that we could develop at HAIO? What would be interesting to the architecture and engineering community that they can focus on for issues over the next year? And that parking lot will be an opportunity for us to formulate future sessions, and also if there's collaborative exercises that would be important. First, I'm going to ask for a welcome from Richard Barnett, the founder of HAIO, then some opening remarks from Dr. Peter Slavin, and then the first panel with healthcare executives, roundtable, and then John Meservey is going to provide some remarks, and then the second panel with facilities leaders. Richard, if you'd like to start, and certainly thank our participants today that will be able to join in.
Thank you, Stan. Good morning, everyone. When John Meservey and I started HAIO, I don't think we ever imagined that we would have this incredible group of talented and dedicated people. We're so extremely grateful. We hope that today's meeting will help us identify additional opportunities for HAIO to continue to schedule to service the healthcare community. Thank you all, and Stan, back to you.
Great. I'm going to turn off the slideshow so that we can see the speakers in full screen. And with that, I'm going to turn it over. If Dr. Slavin is on.
I am here,
Great,
Stanley.
Great. Thank you very much. Sorry.
Good to see you. Good to see my friend
much.
Richard, and thank you all so much for participating. This has obviously been quite a year we've all been through, and hopefully things will just continue to get better. We all have our fingers crossed that that is the case. I certainly thought when I heard from Richard several years ago about the idea of creating this group and coming up with some out of the box ways to prevent infections or the spreading of infections within hospitals, that was an important issue back in those days. But obviously, as important as it seemed then, it's multiples more important now. We need better strategies for controlling infections within our own walls. We may, in all likelihood, be faced with more pandemics down the road and need to take all the lessons that we've learned from this one to try to figure out ways to better manage future ones going forward. So I very much want to thank this group for the work that it's already done, the work it's going to be doing today and in the future to come up with novel strategies for hospitals and how we can do a better job managing infections within our own midst. And I very much look forward to hearing some of the output from this and other meetings that emerges. So thank you for this group for assembling, and I'll stop now and let you get on with the important work ahead of you during this meeting.
Great, thank you very, very much. I am trying to see if everybody on the call. I wanted to check if John Fernandez has been able to join yet. If not, we will catch him in a few minutes. But I do see Dr. Richard Weiner. If you'd like to speak, that'd be great. You're on mute.
Happy to. Thank you very much. It's a pleasure and an honor to speak to this wonderful group. You guys have been doing great work. Definitely something that was timely work considering the pandemic and even before. So I'm going to share my screen for a minute just to show you something that I think is interesting. So this is, can you see this graph okay?
Yes, thank you.
Yes.
Okay, so this is our, at Winchester Hospital, this was our experience with COVID. Starting back here, we had our first COVID patient March 11th of last year, not admitted, they were in the ER. I say we had our first COVID patient. We had our first patient that we diagnosed with COVID. We may have had patients with COVID before then that weren't recognized as such, but anyway, March 11th, this was that initial surge. Here's the summer when we thought we were all done with it. Here is the holidays, starting with Halloween, going up to Thanksgiving, Christmas, New Year's. A lot of behavioral changes coming down after that surge. And then this is more recently, we were down all the way to about 5 toward the end of February. But then in March noticed an increase again, and that was felt to be due to a combination of factors. Mostly that the appearance of the variants, and also people were starting to be a little more, being less restrained with their activities and their gatherings, in particular, and their masking maybe. me just stop sharing here. Okay. So we thought that was interesting. Now, we have about 12 patients right this minute in the hospital with COVID as inpatients. And the interesting thing is that they're in general much younger than the elderly patients in the congregate setting, SNF patients we used to have. And very few, if any, are fully vaccinated. The fully vaccinated patients are not getting admitted with COVID. They might be developing some mild cases, but in general, we're not seeing them. We also haven't had any staff members come down with COVID, which is usually a community acquisition, in weeks. And we relate that to probably the very high vaccination rate among the staff. So it turns out the vaccination is working in real life like it did in the trials, which is very heartening. One of the common questions that our infectious disease experts get are, can I see my grandkids? I'm fully vaccinated. My kids don't want me to see my grandkids, but I'm fully vaccinated. Why can't I see them? And the answer to that is, it turns out if you are fully vaccinated and you're asymptomatic, that your risk of carrying the virus asymptomatically and transmitting it to somebody else, for example, a grandchild, is minuscule. It's just not happening. So there may be, a anecdote of here or there about it, but in general, it's safe. So my kids were happy about that. I was even happier. We've noticed we've reduced our hours for our outpatient testing tent because fewer patients are getting tested these days. We test for both COVID and flu. We have had 0 cases of influenza this winter. 0. Unheard of. And it's all because of masking, hand hygiene, social distancing. Makes you wonder whether masks will be here every winter. But 0 cases of influenza we've diagnosed. As far as where I think it would be helpful to go in the future, what we've learned from this is be best if as many rooms as possible were negative pressure rooms. If we had surge spaces that were really designed to be used as ICUs or floor beds if they weren't floor beds before, but are more often used in their normal capacity. But if they did have to be used for surge space, to have it be, appropriately set up for that. To certainly have larger waiting areas where we get spatial distancing if necessary. Screening stations that are designed appropriately for entrance. We separated people coming into the hospital from patients being discharged. This pandemic, we had the discharge patients go out through the front door. Nobody was allowed except for staff to come in through the front door. But to have that kind of a setup worked out ahead of time. And those were the high points that I wanted to mention. But again, thank you for all your great work. Appreciate it.
Thank you very much, Dr. Weiner. John Fernandez, would you like to share your thoughts on these topics?
Be glad to. Thanks for inviting me, especially Richard. Thank you. How can I refuse Richard when he makes a call? So I don't know that any of these thoughts are original or new to many of the people on this Zoom. I see some of my good friends like Steve Strongwater. Yeah, hopefully he's invented most of these things. But I wanted to give a few thoughts. I was going to focus them more on the out of hospital experience because I'm sure you all have gotten plenty from the inpatient side. And I think some of the lessons we've learned, or maybe even more importantly, been reinforced, like for example, virtual. This is not a new thing. It's actually done in other parts of the country more than we do it here in the Boston area. But I think COVID made people realize how many new places you might be able to use it for getting in touch with patients. So I think a few of the trends, at least what I was asked to talk about, a few of the trends in healthcare that I think are important for us to think about as we think of COVID plus the environment. One is, how do we do things closer or in the home? Also the on-demand nature of our world. So all times of day and night, when can we make ourselves more available as providers? I think there's an incredible environmental change about who's getting into the provision of care. You only need to look as far as Amazon, CVS, and a litany of other players getting into the space, mostly in niche places, but some of them are getting to be at scale. Fourth bullet, I think, would be making it easy to access providers. So we make it incredibly difficult. Even I would like to vote that we get rid of registration. Like how can we make it easier for patients to get the care that they need and every step along that journey? There's also, I think, more intense care in the places that we've already built. So for example, on the inpatient side, most of those patients are sicker and sicker. And then some of those patients move to the outpatient setting and they're sicker or need more than we had originally designed those facilities. And then some of those are moving to whether it's virtual or home, and that's places we haven't been treating patients. So I think we have to think about that as we have an aging population in our future. Last, I'd say that's very difficult, and Steve knows this all too well, is value-based care is a big part of the future, except for the thing that I'd like all of us to work together and think of a better name. So we're not trying to sell value-based care. It feels like the dollar store. So there'll be a contest that Richard will be running for a better name than value-based care. But we all know what that is, and there will still be fee for service. So how do we design our health system and the work that we do to having one foot in each canoe, as the saying goes? So I think those are sort of the trends. There's probably several others I'm missing, but those are the ones when I thought of this meeting that I think we have to have top of mind. And then how it relates to architects, planners, and facilities folks is, I made 4 quick points here. One was we need to focus, especially our outpatient facilities, on when a patient, not a doctor, but a patient needs to be touched or imaged. And try to leave a bunch of the other stuff to virtual or video or whatever other technologies. Second, I think there's a lot of lessons to learn from COVID, but I would be very careful about over designing for COVID. I think we learned a lot. I've heard of all kinds of different things, like let's pre-build the, how you get vaccinated or tests done, like drive through, like the tellers and the banks of old. I think we ought to be careful about what we build versus what we can make intense and be flexible. And that'd be my third point, is that how much flexibility we can build in while being safe, whether it's movable walls, lighting, carts, technology, whatever we can do to be more flexible, because one day's primary care office could be an ophthalmologist or infusion in a year or 2 or 3. So that flexibility, I think in healthcare, we've long customized versus thought flexibility first versus customizing, sort of a user-centric model to a more patient-centric model that gives us the ability to do lots of things in one area. And then lastly, I guess I'd pitch, I'm not sure it meets with the mission of this organization, but while I have the mic, I'll take it. I would hope we try to find new planning models that move faster, are safer, and reduce customization. All too often, I wonder why it takes us so long to design this facility or that facility. And if we could come up with more standardization, but build in the flexibility, it could save us time and money that we could spend on important safety and patient care matters. So that's my quick version.
Thank you very much.
Stan and Richard, glad to take questions or however you run this thing.
Thank you very much. We're going to keep moving on, but a lot of material there that will be good to catch, and this will all is being recorded and is available for people afterwards as well for the reference. Dr. Strongwater, I'd like to ask if you might add some comments.
Good morning, and thank you so much for the opportunity to talk with you, John. I think you hit many of the highlights. It's always hard to follow you. What I thought I might do is tell you the things that happened, tell you the predictions for the near future, and then ask you for help in a number of areas. I'd say, we are a fairly large practice. We have over 700 docs and over 745,000 patients inside the 495 belt in 30 odd locations. And during COVID, we actually shut down half of our sites. What that led to were delays in preventive care and people now presenting with more advanced clinical conditions, poorly controlled diabetes, hypertension, delays in screening, mammography, and colonoscopy. I heard from Lori Glimsher the other day that from Dana-Farber's, the CEO of Dana-Farber, they're expecting 10,000 excess deaths as a result of those delayed screenings. We've also seen a significant change in our payer mix. That is the decline in commercially insured and the shift towards Medicaid and people on the exchanges, putting financial pressure, certainly on our practice, perhaps on hospitals. It doesn't miss anyone that we survived to a large extent by shifting to telehealth. So virtual care became a lifeblood for our practice, where in the past we had done maybe 100 telehealth visits in the 2 to 3 years prior to COVID. We finished the year doing over 350,000 telehealth visits. That led to lower in-person care, which also negatively impacted revenues because there are fewer ancillary studies done and fewer lower codes for telehealth than there are for in-person care. Triage became much more important. We set up a 100-person COVID resource center to answer questions and triage people to the right locations. Critically important. The other thing I think we've seen throughout COVID, believe it or not, is market consolidation. So we saw a couple of the health plans come together. We've seen the maturing of BILH and their system, MGB, deploying more of an ambulatory strategy that John knows well and is likely in charge of. So just my top 5 reflections on the year. Where are we going? What are the predictions? I think digital health is going to transform the way medicine is practiced in this country. The regulations will catch up for cross-state licensure, for a variety of reimbursements. We know that telehealth for behavioral health is really the new normal for a variety of reasons. I do think telehealth is going to be impacted by the big players. We're talking about Amazon. We're talking about big technology companies, Google and the like. And so the face of medicine will be transformed, and it of course will have an impact on the physical needs in support of healthcare. John said population health. I do believe population health, better name than value-based care, but population health is also an increasingly strategic component of local care in Massachusetts. And home care and the use of ED at home, meaning paramedics deployed to the home to avoid the use of ED, is going to be an increasingly common practice to free up inpatient beds for more complex patients. I think that artificial intelligence to filter out unnecessary kind of home-based monitoring. Everybody's got a device of one sort or another, whether it's your watch or a sleep aid or whatnot. We're going to see AI filter that out and get triage to the right people for the appropriate interventions. I mentioned triage as being so important during COVID. I think triage is going to be a much bigger part of care in every system in Massachusetts. Triage for the site of service, meaning to free up beds in academic medical centers, to shift care to community hospitals, to triage, to get people to use paramedics before they jump in an ambulance. So triage, I think, is going to be a very big deal. We tend to not think of this in facility terms, but diversity, equity, and inclusion is also going to be an enormous focus in healthcare broadly, and how that will translate into the locations for various facilities and access generally is a little bit unclear. Just the general comment that the shift to ambulatory care, even though we've been saying this year after year, and to the home, as John pointed out, is just accelerating. I think you'll see it in this market. I think it's going to be an important component of managing total cost of care over time and to create inpatient capacity for sick patients. What about the future? How could you help us? In the ambulatory space, I think we need contactless check-in. That is to say, you can go into an airport, you can get all the way to the front gate through TSA without, in essence, touching any other human being. We need that. We need better privacy if you do check in at the check-in locations. How are we going to deal with that 6-foot distancing in the context of facility design and kiosk placement? And how will our signage, if it needs to change, actually change? I think there needs to be a new look in the ambulatory space at how construction now and the needs for physical space are going to evolve. What do I mean by that? In the telehealth era, how many exam rooms should we be? How do we size our new ambulatory facilities? How do we design for hybrid office needs, for back office support staff? Work from home is probably not going to go away. So does that allow us to shrink our footprint generally? I think that in hospitals, we tend to think of air handling, but in light of COVID, air handling turned out to be a problem in almost all of our ambulatory spaces. We set up respiratory-free sites, and those sites that saw patients with respiratory symptoms, we had a small van pull up with HEPA filters for every room. It became a little bit awkward. So what the air handling needs are in the ambulatory space, I think, will be really helpful and important. I think the other questions, and I think everybody is thinking hospitals because there are these robots that can kind of sterilize rooms, but what are the cleaning standards and what are best practices for the ambulatory environment? What has to be cleaned? How often does it need to be cleaned? We don't do a terminal clean in the way an OR is cleaned. So just top line, help with design, help with cleaning, air handling, and the like. That would be my wish list.
Great. Thank you. Thank you very much. Would like to move on to Wynn Brown and then Vincent McDermott after that. So Wynn.
Yeah, thank you, Stan. Good morning, everybody. Thank you for putting these sessions together. I appreciate it. So Haywood Healthcare, we are west of the city, 60 miles, rural, limited resources, older population, poorer population, legacy facilities that we live in. And so it's nice to see that our two architecture firms we work with and our developer are here as part of this process, because we're in the midst of some projects with them. One is I see that we're looking at that's already been mentioned is just the move to outpatient facilities and making a decision between building new or renovating what you have. And clearly we need to have less friction is a trend in the process, from, as we've already talked about, pre-checking in, pre-registration, how many touch points are there in the process, how do we discharge with less contact, and then what are we doing for cleaning in between? What do the spaces need to look like that need to be big enough? Clearly our 10 by 12 legacy exam rooms probably aren't big enough anymore. And a big issue that we're dealing with and we've dealt with, already mentioned, is HVAC and air quality, and how do we handle that in the outpatient setting when we build new? What's the standard? And then what are some creative ways with our different HVAC systems that we might be able to improve them without wholly replacing them. If anybody's replaced rooftop units lately, they're incredibly expensive. So how can we look at that from an outpatient flow perspective? The other piece is helping us figure out how to do things from a trend perspective that's affordable. It's getting more and more expensive to build now. And so what are some standard affordable solutions for those who don't have the resources to, do a lot with a lot of money when you have a limited budget, and thinking about how we can be effective, creative, flexible, and affordable in different care settings, whether it's inpatient in a legacy or new facility or an outpatient facility. And then time. As we look at this, time is the variable that a lot of people look at. How much time does it take to do things? And as we've sort of, jury-rigged our way through the pandemic, everything takes longer, from getting into the facility to registration through discharge. What can we do to streamline the process? I know we've been grateful with the architectural help with our entries. How can we make those more efficient and make them safer? But thinking about just the flow through the facility is in this mid to late pandemic situation that we're in. We're keenly focused on surgical services and are in the beginning stages of designing a new surgical platform. And we would love to see the best thinking from infection prevention, HVAC, patient flow. A lot of the ways that we flow patients, we've done historically for a very long time. We're based on a model and a platform that everybody grew up with. Is there a new way to do it that makes it more efficient, costs less to do, and is safer for everyone? So that is something I'd love you to consider. The other piece is some best practices, which we've already done some work with this group, is just around entering and exiting facilities from our entries. We have a lot of constricted entries. What are some options for flow that would be helpful? And then cleaning was just mentioned. What are the best practices around cleaning? How do we make it easy? Given the way we do clean now, are there easier ways to make sure that we can disinfect rooms between visits? We can't have UV lights necessarily in every room, but maybe we can without moving the robots around. What can we do? And then just the advent of digital health. Obviously, we now have a pass to actually go deep into telehealth and use devices at home. And how do those integrate with the work we do and into the flow? And so I think flow is a word that we need to consider in this, and making sure that we take out the friction to make it easier when we might have to do more to stay safe. So those are just a few comments from west of the city.
Thank you very much, Wynn.
Thank you.
Great comments. Vincent McDermott, back to the city.
Yeah, thanks, Dan. Vin McDermott at Newton Wellesley. I'm the CFO at Newton Wellesley. So it's interesting to see my friends that went before me and the commentaries they have made as the headliners, and where the CFO sort of folks rank here in the last, pulling up the rear, which is totally fine, totally fine. I think I understand now. I don't know if John Fernandez is still on the call, but it became evidently clear after listening to him why he called me late last week to get my insights in what I was going to say, because I think he just used it all on his commentary. So I'll try not to be duplicative, because after 5 or 6 people answering the same question, you tend to the themes start to run through there. So I'll be selective in some of my commentary to keep it brief, so that it's not, and try not to be duplicative. But through what we've heard, I think many of the issues and concerns are the same. I would say maybe what's different a little bit in my commentary is the most immediate concern I have is just sort of, how do we operate today, tomorrow, next week? And we've got some staffing concerns in terms of our people that have come through the COVID. We talk about facilities and infrastructure, but we also can't forget that our staffs have come through this pandemic and have been very challenged. So I think as we come out of this, as much as we want to keep the pressure on and pushing volume in many different settings and continue the work around infrastructure and facilities, we've got a very tired, very worn out team of people that we're going to have to balance that out. I think also from a more current threat, probably for many of us, and some of these comments were made, while the pandemic raged, business carried on for a number of organizations, and some of them are our competitors. The CVS kept moving right along. The outpatient surgical centers in a couple of different areas have opened up. The new entrances into primary care through companies like One Medical, those will continue to be threats, picking off some of the hospitals' more profitable services that can be moved in this shift to outpatient and eventually to the home. I think I treat that as sort of current threats that continued throughout the pandemic. Maybe an awakening threat that the pandemic exposed was these deferred maintenance and sort of infrastructure issues. We are not set up well as an industry to deal physically, in terms of reacting to a pandemic. I think that lots of investments at many of the community hospitals that I've been involved with, they are needed in terms of infrastructure and what's behind the wall. Many hospitals have spent time focusing on the pretty stuff that's patient facing, and it only takes a pandemic to sort of expose some of the concerns and issues that have been discussed here today. So the continued investment around infrastructure and resiliency, of which within our system at Mass General Brigham, John Meservey is one of our leaders on that, and he needs to continue to push that agenda. I think we did a lot of things well. We quickly shifted to virtual visits overnight. We quickly needed to figure out how to see patients in the hospital, how to change waiting rooms around, create distance, end at some level of visitation, and how do we just better process patients through, many of which comments have come up here already, so I won't spend a lot of time there. I think from a design standpoint, and John did focus on this, John Fernandez, flexibility is a key for space. Our space is very valuable, and building it out to be flexible in the future will be critical. But how do we do that with being cost conscious? And I think that the flexibility in the design to create redundancy will add cost, and it's often those types of costs that get cut out of projects when you try to build in the redundancy on the initial construction of the project. So that's going to be a challenge. I think that having that future flexibility will allow us to be able to flip better and faster and quicker to deal with future issues that may come up around a pandemic. And certainly here, we saw that we needed to provide immediate surge capacity. So what in that space can we think about from this group of folks in terms of having access to or creating surge capacity either in the hospital or outside? Reconfiguring of entrances to separate, as one of the previous speakers had mentioned, infected and non-infected patients and processing them through. We found in our hospital, establishing a secondary ICU, it didn't necessarily have all the infrastructure that was required to do that, to increase emergency power or medical gas supply. And so how do we build in that redundancy in future design? I guess from a CFO perspective, I'm fine with flexibility in design as long as we create flexibility of use down as we open up those new spaces. If we don't, then the cost curve is just not sustainable from a construction standpoint. If we've designed flexible space that we don't then use on a flexible basis, we can't just build it for pandemic purposes. At the end of the day, I think that hospitals across the country and the demographics of the country, we're moving towards hospitals being there for the sickest of patients. And as the baby boomers age, we as a society, we haven't seen a patient population live as healthy for so long. And so this is going to bring a new set of challenges and opportunities, especially for those who can figure out those challenges. But so I'd probably stop there and offer those up as some of my thoughts on the current emerging and long-term threats that and/or opportunities that I've seen come out of the pandemic.
Thank you so much. And I just want to do a quick time check. We have about 20 minutes left. John Meservey is going to share some remarks on his thoughts from what we've heard so far and going forward. And then we have Steve Carberry, Nancy Handwright, and Dominic Gagnon. So that's about 4 to 5 minutes each. And we'll have a minute if we keep the four minutes or so, we'll have just a few last moments to say thank you at the end. So John, if you want to
Thanks,
go
Dan.
ahead.
Yeah, and I'll, in the interest of getting to our next set of guest speakers, I'll just hit on a couple of things that I heard as a facilities person. And that's everything from the flexibility to adapt space relatively quickly. As several folks mentioned the need for surge space, and it's not only space, obviously, but it's infrastructure to support that surge space, and that takes us into the realm of limitations of existing infrastructure. Vin just talked about some of the aging infrastructure that we have in our facilities. I'm sure many other hospitals are dealing with the same issue, and a lot of those limitations were highlighted when we tried to push more air through our buildings and increase the amount of exhaust air to create a sort of negative pressure effect in many of the spaces that we wanted to protect our staff in particular. The flow of guests, patients, visitors through public space, entrances, exits, registration. I think that's a really significant challenge for many of us. If anything, one of the things that we've been doing is shrinking the amount of public space we have at the entrances of hospitals, because at the end of the day, it tends to be expensive space and it tends to be non-productive. And if anything, given all the kinds of things that we presently are activities that we're trying to support at the front entrance of a hospital, we would need to expand it. And that takes us into the realm of, okay, so what are the alternatives? And so pre-registration, electronic pre-registration, self-rooming if you're in an ambulatory environment, having separate exits, significantly distanced from entrances, that I think works well on a practical sense. I think it can be disorienting for a lot of patients if they're, where's my car? If you're parking your car in one place and coming into a hospital and having to leave by a different exit, how do I get to my car? So there's a whole lot of issues associated with that around wayfinding. I think what's really interesting was, and Steve Strongwater mentioned this, what's the cleaning protocol? What's an adequate cleaning protocol for an ambulatory environment? Recognizing that, we do not do a thorough cleaning like we do in an inpatient room when the patient turns over. And then finally, how can we build faster, smarter, flexibly, and again, be able to adapt to the particular demands that are being put on our facility from week to week without having to go through a major construction program. There are costs involved in building in flexibility. And so the point that Vinny was making, it needs to be flexibility for a purpose. It needs to be flexibility that you really have determined you need. And it needs to be flexibility that actually works. If you say you can move walls around over a weekend, let's make sure we can move walls over a weekend, and it doesn't become just as long to do that work as it does if you had fixed walls and you lose the benefit of the premium. So I'll stop there. Thank you.
Thank you very much. The second panel that we have are three leaders in facilities aspects, and so wanted to get an opportunity to dive into some of the facilities aspects of look ahead of the next as we emerge from the pandemic and vision of the next year and beyond. Starting with Steve Carberry from Yale. And thank you very much for joining us, Steve.
So good morning, everybody. Thanks for having me. Really appreciate it. Steve Carberry, I'm Vice President of Facilities at Yale New Haven Health System. We've spent a tremendous amount of time looking at lessons learned throughout the pandemic. I think we're still writing the book on it. It's not finished. But we had the opportunity to take a look at our large $800 million new tower project that we put on pause during the pandemic. And we've restarted it now with really taking a look at how would we adjust the design of that project with lessons learned during COVID. And, we've got 7 task forces right now looking at all the lessons learned. A lot of what has been discussed today, and I'm not going to rehash all of that. We've all talked about air handling and flexibility and cleanability and all of those issues, surge capacity. We're looking at all of those. But I think one of the real focus points that I'd like to cover is the effect on ambulatory. One of the first things that we had to do during the pandemic was really shut down our ambulatory clinics within the inpatient towers. We do have quite a few offsite ambulatory locations we were able to keep in business. And I think that helped us tremendously with a lot of flexibility and being able to move stuff off campus and then convert those inpatient or those outpatient areas to inpatient care during that period of time. So that really, caused us to really take a look at, is it still the smart thing to have outpatient facilities within these expensive towers? We knew, prior to the pandemic, it was probably not desirable. Who wants to have something that can be in, $30, $40 a square foot space and something that's $1,000 a square foot, if you were to look at it on a cost basis. So with our tower project, we actually had 2 clinics built into that tower. And so we're really now challenged to move them out of that tower and find a new location for them within the city of New Haven. So, that is probably one of the big aha moments. People will always perceive an ambulatory site as quote unquote safer. And, we don't need to have that within the tower. So that look at our ambulatory spaces, and as everyone has said prior to this, and re-looking at it, how can we make it flexible? How could we do it cheaper? Once we move some of those clinics that are in existing space, the pressure from, the reimbursement community, we know provider-based is no longer going to be a thing. So, we have to now compete at a different price point. So as revenues are lowered for those locations, we really need help from our design community to help us in the hospital community rethink ambulatory. We know how to build them. We know how to build them very robustly. We take inpatient folks and move them to ambulatory locations, and everybody likes all the same stuff there. So I think we really need to rethink it and come up with new delivery models on how to deliver that. The other thing that has really been a big impact, and it's been said before, is the impact of video telehealth on those locations, and what is really going to be the impact of that. Pre-intake visits, sure, those can be done on video. There probably still has to be some hands-on clinic visits, and then maybe post follow-ups can be certainly video. So we're really looking at the huge surge in video telehealth during the pandemic, and oddly enough, it spiked. It seems to have come back down now, and our CIO keeps saying, well, if you could do a video visit in November, why can't you do one today? So a lot of pressure on the physicians and scheduling to really take a look at that. I think the other big benefit was the huge uptick in making sure everybody was on the app, whether it's MyChart or whatever electronic app you have for specimen testing, certainly drove it there. And we're glad to see that, because that also is a great link to video and telehealth going forward. So I think those are the big things that I want to focus on. There are tremendous other topics we could probably talk all week on, but the ambulatory space is really going to continue to be pressure for us. And I'll stop there and yield my time.
Great. Thank you very much, Steve. And I just note we have about 10 minutes. We have Nancy Hanwright and Dominic Gagnon, and then some closing remarks. So we may be over just a minute or a couple minutes past 11 or 12, but want to keep all these great ideas and thoughts coming in this opportunity. Nancy, thank you for joining us today.
Thank you for having me. I'm Nancy Hanwright. I'm the Senior Director of Real Estate and Space Planning at Boston Medical Center. Not surprising, since we've all had the same questions, that there are consistent themes, I think, in all of our panel discussions. As far as emerging thoughts and trends in the marketplace, the discussion on encouraging the use of telehealth without overusing it, I think, is important. Increasing care and patient provider trust. We've seen the benefits of that during COVID, and so encouraging that continues will be key for us to actually be able to gain space within existing hospitals that we don't have today to build these flexible spaces that we need, right? So at BMC, we had an average 20% no-show rate in our psychiatry department. And with telehealth, on some days it was 0%. And so now we are looking at that and saying, okay, can we take 20% of psychiatry space and build something that is more usable, maybe group rooms or things that the hospital can use for other uses. So just making sure that you factor in those space savings into your space planning. John Fernandez mentioned earlier to not overreact. I think that's another thing that I had on my bullet list in terms of HVAC demand and really taking the time to understand what that impact really is from a cost standpoint and an environmental standpoint, I think is important. Not rushing to privatize rooms. While that is clearly important and needed, there are downstream effects, with regulations to do that. You will ultimately end up with less rooms, so then see less patients. I think COVID, it was like signage overload with COVID, right? You should see trends with more digital signage, which I think is great, right? We need to eliminate visual clutter. People get stressed when they can't figure out where to go. But we also can't forget that the best way to get people is to actually see a face, right? So providing the space to have that ambassador there to actually help people. Getting into the communities, also another thing we talked about. So these mobile vans, we used them at the beginning of the pandemic to reach our pediatric population. We had parents that didn't want to bring their children in for vaccinations. And so leveraging that and now getting out into the communities to do vaccinations is another thing. I think it's another trend that you'll see more and more hospitals doing, maintaining camaraderie. So wonderful, great leaders here. I think maintaining that so that we can all be innovative in the future, maintaining these relationships will be something that hopefully we will be able to maintain. As far as issues that are evolving, I think we need to make sure that FGI and the DPH guidelines keep up with with the speed of technology and the changes there. And maybe revisit the mandate of private rooms. We need them, but we also need to, because of the increase in privatization, we've actually taken away a lot of our surge capacity in hospitals, right? Loss of the ability to actually flick the switch from positive to negative air. We used to be able to do that at one point. Maybe we need to rethink that. Increased size rooms equal less beds. Building in flexibility, everyone's talked about that at this point. And then just, again, thinking about the downstream effects of what we do today and how that impacts patient cost and patient access in the future.
Excellent. Thank you very much.
You're welcome.
Dominic, would you like to join us? Great. Thank you.
Absolutely. I've been here, just had my camera off. Thank you all for having us. Good to see a lot of folks on here, a lot of familiar faces. So I'll try not to touch on things that have been talked about at length, but I do tend to side with John and Nancy's comment about reservation and not overreacting to our current situation just yet. There will be a lot of analysis on this post-pandemic. We are still seeing waves. We are seeing variants that, people are not quite sure how are going to play out. Might we be in a cycle of, until this is handled globally, could we be in a cycle of ups and downs over a several year period, which may have different impacts on what the results should be, or how it would impact us in other ways, are some of the things being tossed around right now up here at Maine Medical. With that said, jumping to some of the specific items we've been challenged with that we're thinking quite a bit about, blended units. So as surge became a problem and capacity became a problem, and you talk about flexibility, what does it mean to have ICU, IMC, and med surge on a given unit? Can you split it across the unit based on pods, based on how that suite separation may be, and so forth? The other challenge being staff areas. There's not been a lot of talk on this call just yet, but the second wave hit us pretty hard up here, much worse than the first wave. And the staff space became a real problem when you started to factor in distancing. What do respite areas look like? Where do they go for breaks? Where do they eat their lunch? We started taking over conference space and waiting rooms and other things to allow staff that space. And that was with reduced, staff rates. Number of people out has been mentioned at some other locations. What is the impact of that staffing, the reduced staffing? How many will be burnt out through this and may not return to this industry? Or how will it be a call to service for others, and will it increase? Really trying to look at those impacts. We recently built a 2,400 car garage about a third of a mile away, and the shuttles, the employees are shuttled in. When you reduce the capacity of those shuttles based on distancing, we had some significant impacts on how that works. Converting over visitor spaces to staff parking, seeing that visitor policies were, implemented at that point. Length of stay became a problem. When you think of the SNFs that had all types of restrictions and had their own problems, we started seeing length of stay here in the hospital increase dramatically. Patients that we just could not place elsewhere. When you think of the geriatric population that you would want to get into some other location, has had a tremendous impact. That's also a revenue impact. There's other side effects to that, but it created more of a surge issue. Alternative care sites, and that was worked on early on by HAIO and this team, but it still continues to be an issue. And that tied into testing, it tied into vaccinations now. Standing up these vaccination sites became quite an ordeal the last few months. And we have a couple of large ones, including Scarborough Downs, which is not unlike some of the large facilities you have in Mass there. So we're continuing to look at these things. The flexibility component is a big one, as mentioned. Telehealth, some of the questions we're getting is, providers wanting to do this from home. So how does that impact an MOB if telehealth would allow them to do it from various locations? Do you need to provide that space and that resource in an MOB setting, or is this done in some other fashion? It will have an impact. We just don't know what that is right now. PPE being another one. We all dealt with PPE early on, but just the simple donning and doffing as various units within a hospital are converted to COVID units. Do we have the space to store? Do we have the space to don and doff safely? What is the impact of the PPE on the environment? And that was seen throughout. We did have the advantage of some of our older buildings having operable windows where we could drop in modified exhaust fans and create negative rooms very quickly on a room by room basis. There's something to be said for that, even though our new environments tend to have windows that are not operable. We were blessed in having several, units that we could do that in. So with that said, I'll kind of leave it there. We are at 12 o'clock and I want to respect everyone's time. And a lot of the items did come up across the board. So thank you.
Thank you so much. And I do want to thank all of our speakers today. The list is here, and which I presume we can see. And Richard, would you like to share some final thoughts?
Sure. Thank you, Stan. I want to thank all of our speakers and attendees, and especially you, Stan, for all of your tireless effort in pulling this together. It's no easy measure to do this. And we will be doing this again very soon, and we will update everyone for our next meeting. Great challenges and great ideas to help us help everybody on this call. So thank you.
Great. There was a lot of information today. We were going to, this has been recorded. We're going to, within a few days, we'll send out the link to that recording. And as Steve Carberry said, we could talk about this all week, these topics, but I think this was an incredible opportunity to get a lot of ideas out there, and certainly we have identified many topics that we can follow up on more focused. Thank you again, everybody, for your participation. And
Thank you.
with that,
Thank you.
thank you.